Okay, we are live now.
Okay, great. Okay, welcome everybody on this absolutely beautiful September day. Thank you for joining. We have a full agenda, primarily the executive director's report, and then a discussion that'll be very interesting on issues related to understanding affordability and MHIS, as well as the analytic agenda for Chia. So important topic. I am going to start with the minutes, which were mailed out earlier. I'm assuming, does anybody have any corrections, changes? I'm going to assume no. Okay, now I'm going to have to ask for a roll call here because we are on Zoom. So please unmute yourself. And when I call your name, say yes if you approve it or no if you don't. So Laura, I will start with you.
Yes.
Thank you. Rob.
Yes.
Lauren.
Yes.
Meredith.
Yes.
Niels.
Yes.
Cassandra.
Yes.
Thank you. Colleen.
Yes.
Did I forget anyone? No.
I also vote yes. Okay.
Sandy, how could I forget you? I'm sorry. You're one of the very few that's actually on my screen. Thank you. Okay, minutes are approved. I'm going to turn it now over to you, Ray, to do the executive director's report. And I know you've asked some of the other staff to join you on various topics, so look forward to a good discussion. Thank you.
Great, thank you very much, Chair Donahue. Welcome, everyone. Good to see everyone. We can jump right in. Alex, are you able to show the slides that I sent over? Can we?
Yes, they're all ready to go. Yeah.
All right, great. I'm going to start off with a brief finance update, and then we'll turn off the presentation, but I actually do have a little bit to show on screen for the finance update. If you could go to the next slide. Yeah, thank you. Okay. So Chia's FY22 spending has been approved at the $28.9 million. And just as a reminder for folks that Chia's account is fully assessed, meaning that once the legislature has appropriated funds to us, we assess that full amount on hospitals, health plans, and ambulatory surgical centers. So the Chia's funding is ultimately borne by them, not by the general fund. Now, in the past, I haven't been giving as detailed financial updates because Chia had been kind of going through the whole CHRTIF, or Community Hospital Reinvestment Trust Fund process. It resulted in kind of our budgeting being unusual. We've now come out from underneath the Community Hospital Reinvestment Trust Fund payments. And so kind of returning to normal budget times, I want to start returning to some of the more normal forms of financial updates. And so this is not a complete financial update by any stretch. It's just an attempt to start kind of the sharing with the board, the Oversight Council, relevant financial information about Chia. So the most important thing is kind of our spending. And it starts with our appropriation. As I said, it's $28.9 million for fiscal year 22. The major categories of spending that Chia has are in front of you at the bottom of the slide. The next slide will show it graphically, but just wanted to kind of show you the major categories rather than getting too granular. Note this does not include capital spending. And so we're finishing off it's the final development work on the all-payer claims database project is actually happening this year. That's being paid with capital funds. Capital funds are not reflected in this spending. Although I will say, if you add this up, it's more than 28.9 million because Chia has other sources of revenue. We have data sales that we're allowed to retain the revenue. There are certain kind of technical state government things like collective bargaining draw. I think in years where there's raises, there's certain funding that's made available to agencies for that. There's various other sources of revenue in addition to the appropriation, but that's the lion's share of our funding and our spending. Okay, if you could go to the next slide, please. So this shows that same spending, the major components, but portrays it graphically so you can get a better sense of the relativities. As you can tell, payroll is by far our largest spending item, which is typical of agencies. You'll see next, and the letters on the left, AA, UU, HH, that's state accounting terminology, the object classes they're called. And so I retained those. For those of you in the private sector, it's state terminology. What you'll see is the green bar, the second one, IT and data operations, is a significant part of what Chia does because we are a data and analytics agency. And really a lot of who we are and what we do starts with our data and data operations. So you see a significant expenditure there. And then after that, kind of the items drop off significantly. HH consultants, I think the single largest portion of that is the mandated benefit reviews that we do for the legislature, each of which requires the services of an external actuary. And then Chia also uses some consultants. Debt service now for the first time. This is Chia, the way we were able to solve for the $45 million in CHRTF payments was partially to use some agency funded capital. And so now we have some debt service payments showing up in our spending. And then rent, and then everything else besides that, and there's lots and lots of categories, all falls into a number, of around $1 million. So I'll stop there. There aren't any more slides on the finances. Like I said, this is not a complete review of the agency's finances. You'd have to get into, like I said, the revenue sources, kind of the different programs. I mean, kind of over time, the goal is to actually start providing that type of detail. But for today, since it's a full agenda, I did want to just start with some information. And so this is the Chia's FY22 spending. I don't know if there's any questions or comments.
Any questions from council members? I have one simple one. Is IT and data operations include payroll too, or is it just the servicing of licenses and all that sort of thing?
I know it's the payroll for all that is covered in the bar above. That would be the costs of everything from the cloud. It would include like consultants that are working directly on platforms. And so that doesn't show up, I don't think, as consulting, and it doesn't show up as payroll. The people that are actually helping like build the platforms, these long-lived assets, I think that if they're employees, it shows up in this AA. But I think there are consultants we use. So it's hardware, software, licenses, maintenance, all those things, and some people that are involved in building and maintaining that stuff.
Ray, do you can you give me a sense of the full-time equivalents for Chia now?
Yes, and all of these things, like we can sort of dive into in more detail in future sessions. In terms of headcount, there's sort of two ways of looking at it. I think our FTEs is around, and I apologize, I didn't prepare, kind of that specifically for this meeting. So these are kind of rough guesses, but they shouldn't be too far off. I think FTEs is around 155, maybe 160. But in terms of seats that we have to plan for physical space, because we also have, there's part-time people, there's vendor personnel, there's contract employees, there's other, that number is more like, I think, 190. So anyway, but it's around 165 for 160 full-time equivalent employees. And that's what would show up in the AA. Those vendor personnel, they would show up actually in that HH or UU buckets.
Thank you.
You're welcome. So I'll plan on, sir. Oh, is that Meredith? Did you?
Yeah, sorry. I was just curious with all of the changes, roughly how has this distribution changed? I would have thought relative to last year, we probably have lower consultants and relative to our old steady state, do we have many fewer folks or much less investment in one category or another? It seems like the platform for Chia has changed so much. I'm just curious how it shifts the distribution just at a very high level.
I think at a very high level. Well, so I can really only speak to kind of in my tenure, the 5 years. Chapter 115 had just been passed, and so we downsized sharply, which
Right.
reflected itself in the AA. We didn't do any layoffs, but we essentially stopped all backfills. And so you saw a pretty significant drop off in our AA spending. The UU is actually bore the brunt of our budget balancing. So we just cut contracts and contractors and vendors, kind of to the greatest extent possible. But on some levels, that spending, you're either going to be a much less of an agency, or that spending had to come back. Is really the truth. And so what you see here is what the UU had gone, it was probably about this level 7 years ago.
Okay.
And then it dropped sharply as we balanced our budget. And then I brought it back up kind of as the CHRTF has been coming to an end. And as we've been able to fulfill those obligations, our primary goal has been to have a great data and analytics agency for the Commonwealth. And so we didn't try to hold at those sort of, levels of the cuts that we implemented immediately after the passage of 115. We cut as much as we needed to solve the Chapter 115 challenge, which we did. And, that we're now kind of rebuilding or have rebuilt kind of the agency. So anyway, and I guess I could also show a chart showing how this changes over time. But the truth is what you'll see is a dip in overall spending, and then it has rebounded.
Actually, I think that would be really helpful. And as you mentioned, we're going to get into the budget in more detail at our next meeting, which also will be terrific. But changes over time are helpful.
Okay, great. Happy to.
All right. Any other hands raised? Great. Okay. Thank you.
Okay, well, with that, I'm going to turn it over to Emma Schlitzer, who's going to give an update on Chia's publications, recent publications. And with that, Emma, take it away.
Do you mind going to the next slide? Perfect, Alex, thank you. So as we've done in last meetings, I'm just going to briefly walk the group through publications that have gone out since our last meeting in June, and then we'll take a look ahead to see what's coming up next. So since our June meeting, we've done 2 quarterly updates. One has been on hospital inpatient discharge data, and the second one was on hospital financial performance. Both had data through the end of March 2021. We've also continued to report on health insurance enrollment. That comes in the form of our biannual enrollment trends, as well as our monthly enrollment monitoring, and both of those reports were released earlier this month. We also did our annual update on relative price and provider price variation. We had a new report from our case mix data on emergency department data. That was for FY19. We also had a new research brief focused on unmet social needs, and we released one of the editions of our newsletter, Data Matters. Regarding data assets, we released case mix EDD data. So looking ahead to see what's coming up in the next few months, we will be doing a lot of reporting on hospital financial performance with a few quarterly updates, as well as our FY20 annual report that will be coming out actually later this week. We will be doing an update to our provider quality interactive dashboard. We will have a new report also from that case mix series focused on outpatient observation data that will also be for FY19. And then we will be doing a quarterly update to our inpatient discharge data, as well as an annual report on that data set for FY20. And then on our last slide, we will also be doing a hospital-wide adult all-payer readmissions in Massachusetts, report on that. And then we will be developing 2 new chart packs focused on health equity that will be based on data from the Massachusetts Health Insurance Survey. And then regarding our newsletter, there'll be 2 more editions coming out following our cadence of every other month. So that will be September and November. And then regarding data assets, we will be releasing case mix outpatient observation data, as well as release 10 of the APCD. Are there any questions?
Anybody have any information helpful? How have the new ones been received?
The new report?
Particularly the social one. That was just an interesting one.
That was back in June, I believe. It was received well. I think there's a lot of interest in that area. We've been doing, and you're going to hear more about it later, but we've been doing a lot more reports utilizing the MHIS. So I kind of summarized that all of the stakeholders were definitely very interested in what that brief contained, as well as the new reports we've been doing on case mix data.
Great question, Faye. And actually, we're about to hear from Andrew Jackma about kind of understanding Chia's impact, which looks at some of the metrics around kind of understanding, when we put something out, how do we know everybody's listening? And so it'll actually get into some of that. So, but it's also true that some of this stuff, there's a fairly narrow but very influential niche of people that are interested in the topic. And so it's kind of less a mass appeal, like we don't sort of hear lots of people, but we hear targeted responses that are very encouraging. So but I do think that trying to understand and measure our kind of the reception of our work is very important.
Yeah, I agree. I have no idea. They're terrific reports. I really think they're wonderful, but I don't know whether who reads them and how much they're read and what people are using them for. And I always think that's important. Having spent so much of my life writing wonderful reports nobody read.
See, Laura has her hand up.
Emma, I'd like to ask, looking at the health equity report, both the cut for geography and the for demographics, I don't know how long we've been doing that report, but in terms of the current demand for information about equity, do our reports, do we get feedback on what it is that we're reporting? Have we been thinking about that if those reports have been going on for a while in terms of just, we know that there's a heightened interest in that, maybe a new take on it in some ways. Do we re-examine what it is that we're reporting and how we're reporting on particularly these two, given the sort of awakening that we've had in the wake of COVID-19?
Absolutely. So I apologize. These should both be labeled as new. These will be the first time we are doing these charts.
Okay. I couldn't recall seeing those before, and I thought either those are new or I'm embarrassed because I've missed them. And so I'm gonna ask how long they've been around.
No, that was our mistake. I apologize.
Great question. So yeah, it turns out, Laura, our surveys are incredibly rich, and there's almost no limit to the number of issues that you can sort of, do by, detailed statistical analysis. And we do collect race and ethnicity and detailed geographic information in our surveys. And so, and there's lots of information in our surveys about access to care, about affordability, medical debt. And so what we haven't really done is taken that lens and decided to specifically use that data to report on health equity, and in particular, geographically, looking at kind of how health equity, because health equity plays out in a number of dimensions. It's not only, it's race and ethnicity, it's language, it's disability, it's income. And so this is an attempt to look at health equity issues across the Commonwealth, but with a geographic overlay. And then the next one is the same thing, but with a demographic overlay. So new work. I'm really not doing it justice. Zizan, our director of research, should be here, and he could really actually, come to think of it, the folks that are doing the presentation on the MHIS and the affordability work coming up are actually deep experts in this. And so our survey data is really go-to stuff for health equity. And we're going to keep going to it again and again.
I can imagine that's going to be a really exciting report that many people, I think that will be one that a lot of people can't wait to get in their hands.
They might read it. This is good.
And actually on a prior slide, there's a report that we put out using this survey about unmet health-related social needs. So everybody talks about social determinants of health. Yeah. What you really want to know is how many people have unmet social needs, because we're all affected by social determinants, but it's the people that have unmet health-related social needs. And so we've used our survey data, and I think other resources, it's definitely the first state in the country that has put out a statewide assessment on the level of unmet, what is the level of unmet needs and which needs are unmet in terms of income, transportation, food, employment security, all sorts of different social determinants of health. So there's a lot going on from our research team around affordability and health equity.
Just another question on that. LGBTQ included?
I'm trying to think. I don't know that orientation is one of the demographic elements. It might well be. I don't think that we've reported on it yet. I will say that we are, as when we get to analytic priorities coming up, the US CDI data specification. EHRs are supposed to have good data around gender identity, and we're thinking about how we might be able to pull that data into our data assets, because it's an important dimension to report on. We do have gender identity questions in this current round of MIHIS that's in the field, so we will have that slice as well.
Excellent, thank you.
Sandy.
Thanks, Laura, for drawing our attention to those two new health equity publications. I was just wondering, in connection with the Health Policy Commission's report that they released last week, which included a dashboard with embedded Massachusetts data and various health equity markers. Is that dashboard integrated with the survey data and this health equity analysis that you guys are planning to roll out, or is that something that's potentially under consideration for integration with the HPC equity dashboard?
I could ask Colleen to speak to that. I bet it isn't, is my guess, that our work's new enough in this area and their dashboard's new enough that we maybe haven't, but they may, I'm not sure. Colleen, do you know what data elements were used in construct? I saw the presentation at the board meeting. It's really impressive.
Sure, I'd have to check, but I believe it's mostly claims data that we used for that.
Yeah, and this is mostly surveys. So I think there's sort of more integration that we can be doing sort of going forward.
No, I think absolutely. And I'm thrilled. I've already emailed the team to hear about these reports coming out. So we're thrilled to engage more deeply with Chia on this topic for sure.
Any questions, Andy? Okay. Thank you, Emma.
All right. Do you want me to introduce Andrew?
Yep.
All right, thank you, Faye. So up next, Chia's Chief of Staff, Andrew Jackmaw, is going to be talking, I mentioned just a moment ago, and it's not something that we've invested a lot in, but it's also something that we're not unaware of. We have ways of understanding various aspects of our impact, and so Andrew's going to speak to that, and then we have plans for sort of doing more of this in the future. So let me hand it over to you, Andrew.
Great. Thank you, Ray. And it's good to see all you council members. Vice Chair Donahue, I know this had actually come up at June's meeting where you'd expressed an interest in hearing us speak to this issue. So hopefully this starts to answer some of the questions that you have about sort of how our reports are being received and how we sort of think about that. Alex, could you maybe advance us to the next slide? But I think before sort of diving into the sort of hard and fast numbers, it's worth just sort of reorienting the group to think about Chia's primary objective, which is servicing the health data needs of our sister agencies, payers and providers, and the research community. And this objective really informs how we think about our work and the targets that we set for publication engagement. While Chia aspires to service as many constituencies as possible, we are most concerned about meeting the data needs of policymakers and the healthcare delivery system. So it's sort of an exercise in going deeper than wider. So as we sort of think about sort of our performance against this objective, there are a couple ways that we conceive of this. One is we regularly review our portfolio to ensure that it aligns with our enabling statute and some of the ongoing policy discussions that are unfolding, the sort of issue around health equity and that discussion that was just surfaced earlier this meeting is a good example of that. We will definitely follow up with the HPC just to understand how we can sort of better align our work with theirs to support sort of the most actionable next steps on that. That's a good segue to our second sort of way of understanding whether we are meeting the data needs of our primary stakeholders, which is that we are sort of constantly actively engaged in a dialogue with our stakeholders. So in advance of any publication and then subsequently afterwards, we will routinely canvass our community just to understand their needs and whether the reports sort of adequately met them. I think whenever possible, we make every effort to incorporate any relevant feedback that we receive into a current version of a report. And if not, we add it to sort of the wish list items for potential inclusion in future publications. And then finally, we look at some of the numbers that we have available to us. So Alex, next slide, please. So associated with each of Chia's major publications, we produce a performance dashboard that looks at sort of user engagement in the 2-week period following publication. And for that, we use data that's readily available to Chia through Google Analytics, our email management service, and our social media accounts. And we look at metrics like email open rate, the click-through rate, We sort of break down our audience to understand who's looking at our reports. We look at the total volume of downloads, our web traffic, ensuing media stories, and then social media engagement. And then a longer term metric that we really sort of always keep in mind is any resultant use in policy development or care delivery. So for example, I'm going to take you through some data associated with the release of Chia's 2021 annual report. We are sort of deeply concerned about whether that report helps tee up the HPC's cost trends hearing and their performance improvement plan process that unfolds in the wake of that report. So it's sort of, we want to make sure that what we are putting out there is in fact actionable and has some utility to our stakeholders. So next slide, please, Alex. So here on this sort of impossibly small slide, we just have a sort of sample of what the dashboards look like. Again, we sort of produce one of these for the 2-week period after the release of each of our major publications in 2021, just to sort of give you a sense of the scale. We've released 29 publications year to date, and we have another 10 that are scheduled for now and between now and the end of the calendar year. I suspect that some of those may roll into early 2022, but that's sort of the total volume of work. And for a majority of them, with some limited exceptions of monthly reports or technical white papers, we've produced a dashboard like this that allows us to understand just how our community is engaging with the reports. Next slide, please, Alex. So here on this slide, we see the total downloads of the annual report in the 2-week period after its release. The bar chart on the left compares the March 2021 annual report against the prior annual report, which had been released in October 2019. We see that in 2021, the annual report received 589 total downloads in the 2-week period after its release. In 2020, that number was 739 downloads. I think normally we would hope that this trend would be sort of heading in the other direction. And in years past, we had seen sort of steady upticks. It's worth noting that in 2021, we released our annual report in the midst of a pandemic. We had also changed the release schedule for the first time. So it had shifted from a fall schedule, which I think our stakeholder community had grown very accustomed to, and we moved it into the spring for the first time. And so I think that sort of, to our mind, sort of accounts for sort of the drop off in downloads that we received this year. Is sort of divided attentions and a new schedule. On the right, we're able to then drill down and examine downloads by product type. So what we see here is while there was a sort of decline in report downloads, the corresponding data books and technical appendices held relatively steady year over year. Next slide, please. On this slide, we're able to see how stakeholders access the report. The bar chart on the left compares year over year downloads direct from Chia's website. We separate this we separate unique downloads from repeat customers. So the portion of the bar that is in navy blue represents people who came and sort of downloaded the report only once. The gray slices of the bar show those who may have downloaded the reports more than once. And then the bar chart at the right looks at year over year email downloads. Similarly, we break out unique downloads from repeat customers. And finally, the donut charts on the right just show the year over year overall proportion of downloads that came through the website versus those that came through our e-blasts. And we see that our website is where a majority of the action takes place, although in the most recent year, email engagement accounted for a slightly greater share. And what this sort of reliance on web activities sort of suggests to me is that Chia does have an engaged audience that is sort of actively seeking out our work. Next slide, please. Here we look at email engagement. On the left, we see that the e-blast announcing the release of Chia's annual report went to approximately 1,600 recipients, just about 30% of whom opened the email. To put this into perspective, based on what we know about industry averages, government agencies tend to have a closer to 22% open rates. So we'll see it in a couple of slides that sort of Chia is consistently outperforming that rate, but I think those sort of benchmarks are helpful to keep in mind when we sort of think about, you know, whether how we might sort of characterize it a 30% engagement rate. But I think we see that as a healthy engagement rate. And then as we sort of move to the right of the slide, we're then able to sort of drill down into our audience. And again, thinking about our primary objective of, you know, servicing the data needs of policymakers and payers and providers, we specifically look at the proportion of our audience that consists of those key stakeholders. So we see that of those who opened the e-blast announcing the release of our annual report, 61% of those sort of were either a healthcare payer, a provider, sort of someone at a sister agency, a member of Chia's staff or the Oversight Council, or a legislator. In this bar chart on the right, you know, we segment each of those audiences, and we set a sort of target open rate based on past performance, and then sort of examine sort of the actual open rate against those targets. So what we see here is that across the board, with two exceptions, that we had sort of outperformed the target open rate that we had set for ourselves. We see that sort of we had established a 22% target rate for payers, and we only got to 21. And for legislatures, we similarly set a 24% target, and sort of the actual performance was 20%. I do think it's worth calling out for the council that what's missing from these numbers are, you know, oftentimes we will take a sort of higher touch approach with our key stakeholders. So council members will be familiar with the type of emails that they receive in advance of the release of a report, where we will reach out directly to the group and share an embargoed copy. We do take a similar approach with our key stakeholders. So while, you know, sort of these numbers represent sort of, you know, actual engagement with our e-blasts, I am confident that we are sort of reaching out through other channels to these audiences, and that sort of it's just sort of a little harder to track sort of all of that engagement. So next slide, please. So here, starting with this slide, we start to shift to just some general trends over time. Here we see that Chia's email subscribers have grown steadily over time. In January 2020, after having sort of neglected some administrative housekeeping, we scrubbed our list just to make sure that we were sending emails to actually active accounts. And that sort of is what represents this dip in the trend line here. But we see that our subscribers have been sort of growing steadily since that time. And we have been staying on top of scrubbing the list just to make sure that we have sort of the best information reflected there. Next slide, please. Here we see our open rate, and that is represented in the blue trend line, and our email click rate in orange, as compared to industry averages for government agencies. You know, Chia has continued to outpace these averages. We have seen some slight declines that we're continuing to keep an eye on. I think it's worth noting that this data does not extend all the way through 2021. This is through the first quarter of 2021. And so again, we were contending with the pandemic period. Actually during that time, the volume of Chia's output had actually increased, as did the corresponding number of emails. So I suspect that some of these declines are associated with email fatigue and again, divided attentions, but it is very much something that we're continuing to keep an eye on just because we don't want to see ourselves slip below those averages. So next slide, please. Because social media is another channel that we use to promote our work, just a few quick slides on our primary social media accounts. Here we see that Chia's Twitter followers have held steady over time. We've seen a 4% growth over 2020 and 2021, just south of 4,000 followers. Next slide. And then LinkedIn is a sort of newer realm for Chia, and we've actually seen some promising returns as we started posting there more regularly. We've had a 130% growth in our LinkedIn followers over 2020 and 2021. Next slide, please. And then again, because I think we are sort of well aware that there is always more that we could do. I think we will continue to look for opportunities to sort of create more meaningful insights into the performance of our publications, as well as increase their impact. So we will continue to track the metrics that we've been looking at. We're also sort of always on the lookout for sort of newer or more meaningful metrics that we could track using the data that we have available. We are currently in the process of building an interactive dashboard that will allow us to facilitate comparisons between all publications. So the report that I sort of walked you through today is a static report that is sort of sent to staff as a PDF. But we're hoping that over the next couple months, we will have an interactive dashboard that will allow them to sort of view performance as compared to sort of any report of their choosing. We are always sort of looking for new strategies to reach our target audiences, as well as establishing new channels for feedback from stakeholders. Next slide, please, Alex. And this is a bit of a non sequitur, but this is another item that Vice Chair Donahue, I think you and other council members had asked about at our last council meeting, and sort of fits in that, our reports and publications are really in service of the underlying data. So on this slide, we see the number of data extracts that went out the door to applicants over 2020 and 2021. This information is broken out by government applicants and non-government applicants, and then sort of broken down along the lines of APCD and case mix. I think it is, I would call to the council's attention that, we see a sort of dip in APCD data extracts for 2021, and there are a couple factors at play that we are sort of aware of. One is there is a sort of cyclical nature to the requests that we get because of the volume of the size of the data that comes with an APCD extract. We have historically seen sort of our repeat customers come back every other year. So we would expect that we will receive more applications for APCD in 2022. Secondly, the pandemic shifted the focus, the analytic focus of the community to COVID-19. The APCD would not sort of have data for 2020 yet, but we were able to sort of switch to a monthly and then quarterly cadence on case mix, which explains some of the uptick in the case mix extracts that went out the door over this past year. And then finally, we had sort of made a policy decision to combine APCD releases 9 and 10 to get COVID data out the door faster. So we are expecting this fall to release 2020 claims in the APCD. The HPC should be getting They're cut next month, and applicants will have access to it starting in November. And this is sort of much sooner than we would have otherwise been able to provide 2020 claims data. And I think that is the end of my whirlwind tour of Chia's performance metrics. I'm happy to answer any questions that the group has.
Yeah, that was great. Thank you. Questions from council members? Laura?
Thank you so much, Andrew. That was really informative. Just a question on that last of the data extracts. Two questions. One, do we have comparative data for 2019 to show the pre-pandemic levels of those? And if we don't have it just sort of top of mind, is it your sense that that looked, as you mentioned, the cyclical nature of it? So we might know that every other year. And the second question being, looks like there was a huge jump in the case mix for 2021. I mean, more than a tripling, maybe a quadrupling of the demand. Can you say what's behind that, or have a thought about that?
Sure. So we definitely have the 2019 data not sort of readily at our fingertips, but I will make sure that we pull that together and share that with the council, just to sort of give that sort of sense of how that has performed over time. Again, I think the uptick in the case mix data is that is where we are able to say the most about the COVID pandemic, because we moved to a cadence where we were collecting data from the hospitals on a monthly basis. So we had much more real-time data available through that asset, and that was sort of where people were able to sort of just derive insights into what was going on with the pandemic.
Now, talk about I don't know that when we were thinking about that, or when you were thinking about that, there was this, thought of what might be coming down the pike, but that was a timely decision because I believe that decision was made pre-pandemic, and at least the wheels were put into motion before we had the pandemic in full swing, or maybe you did it as a result of that, but it felt like it was either very early on or pre-pandemic, and it looked like it proved to be a really important decision.
If I could jump in on that, yes, it actually, it was in response to the pandemic. It just happened really, really fast. And what it was is we would collect the data. The hospitals had essentially 90 days from a discharge to get data to us at a patient level about that discharge. But we would only compile it into a full release on an annual basis, because primarily researchers looked at full calendar years, and just there were a lot of reasons why really full calendar years was about as fast as most people needed to get it. But we had it in a monthly, it was being submitted to us monthly. And no, I'm sorry, that's not true. It was being submitted quarterly. And so we increased the submission cadence to monthly on a voluntary basis. And then we changed that to a mandatory requirement. So it actually was a response to the pandemic. And yeah, it went literally from annual to monthly. And it's now backed off to quarterly, because that seems to actually be, now that 2020 is over, that seems to be about the right pace. But that drove a lot of the demand there. That used to be, there was only a new version every year. Now there was a new version every month.
Great. Rob?
I also want to say thank you, Andrew. Like, that was really informative. And I'm eagerly awaiting Chia's TikTok page. But that said, I was wondering, I did see that you had click to open rate like on your potential metric sheet for the website. But I was wondering if you guys had any ideas potentially expanding that to like funnel analyses, or seeing like how users actually interact with your website, and see if there's any like potential blocks or walls like getting to your reports or anything like that.
Yeah, so this was a sort of narrow slice in the interest of time. We do have sort of more robust web metrics that we try to look at regularly, just to understand the pathways and sort of where people are peeling off. And I would love personally to incorporate some of that into these dashboards in a sort of more meaningful way. So I think if the council is interested, we certainly have a lot more that we could say about that particular issue at a future meeting.
Awesome. Thanks, Andrew.
Other thoughts? It would be helpful for me. I understand the data once somebody comes in, and then you can say how many opened and how many read, et cetera. But I actually have no sort of context to know whether 600 is the right number of people that are coming to it. Is that good? Is that bad? Is that average?
Andrew, can you speak to that State House News Service analysis they did of Twitter followers?
Sure.
I mean, I can speak to it inaccurately without hesitation, but you might actually be more close to the truth.
Yeah, that would be interesting. But what I was really asking, and I'm sorry it wasn't clear, was of the first big group that was reading our stuff. The example you gave on the annual report, for example, and we have several hundreds of people reading it. Should it be several thousand? I have no idea. And then you can get to Twitter.
Well, but I think that the reference to it was that the State House News did a service of who the folks on Beacon Hill are following.
Right.
And it showed the relative, like how many people had how many followers. And Chia is one of the most followed, sort of like after you get by the big names, it turns out that our numbers compare very well across really any agency in state government. We're not as good as the governor, we're not as good as the attorney general,
Right.
but once you get past the top line agencies, Chia is one of the most followed.
Okay.
So I think that gives a sense of the numbers aren't whatever, but we are a niche. Like we're never going to be this sort of mass market, but anyway, it's a reference point.
No, I know we're not going to be up with the pop stars, but that's very helpful for the Twitter following. I guess I was still wondering on the big report, which takes an enormous amount of effort to produce, and it's absolutely fantastic. Is that a good readership or bad? Or do we not know?
Well, I think there are probably more questions than answers. I think as we've tried to conceive of it, we look at sort of like the sort of where the mandate for any of our reports comes from. And sort of, oftentimes the statute will sort of make it explicit who the intended audience is. So the sort of the language in our enabling statute that requires Chia to produce an annual report says that it shall be filed with the HPC and a couple legislative committees. And so sort of like that is sort of what we keep at the front of our mind is sort of like, is it something that has utility to those audiences primarily? And sort of the ability to sort of capture a broader audience is desirable, but sort of not mission critical as sort of how I think about it. Although I would sort of love to sort of be able to sort of have better insights into sort of, characterizing those numbers against other benchmarks. And so again, we'll be happy to continue to look at that and think about it.
And my only thought was, actually, I didn't think it was bad. I mean, it's not exactly going to be, bestseller riveting account, but so given it focus on who we think is going to read it, is it reaching that target audience? But anyway, thank you. Other questions? Great. It was really helpful. Thank you.
All right, so picking up next on the agenda, it says Chia data release overview. I'm actually, for time reasons, and also we changed up the agenda a little bit last week so that we could start our discussion of analytic priorities. So kind of things have changed around a little bit. I think that we're going to return to this topic of data release. This is what we were just talking about, is the number of requests we get for APCD versus case mix, government versus non-government. But there's also other ways of looking at our data sharing and our data operations. For instance, we do a lot of data linking projects now for other state agencies. So I think that we can report back on a bunch of Chia's data sharing or data release activities. So just wanted to, I think, Andrew, thank you for including that as the last slide, because it makes the point that sort of our work product makes its way out into the world, both in terms of the publications, but also just the data that we source to the Department of Public Health, HPC, and others. So we will report back on that. In terms of other updates, before turning to our presentation on the MHIS, I'll just briefly say the APCD project continues to go extremely, it's going the way it has all along, which is that it's been hard work, but very promising. We're very close to the finish. I think we're a little more than a month away from having all of the virtually all of the data into the production environment with all of the enhancements applied to it. So very, very close to actually there'll always be a little bit of a tail on the work, but very pleased that we'll get essentially the system that we set out to build. So more about that. We've talked about, we just reported on in the last meeting. In December, it'll be fully operational. So that's probably a better time to do a full report.
That'll be exciting.
Thank you. And then one last note before turning it over to Christine and Bridget is that we've been recently going around and meeting with stakeholders on our primary care and behavioral health spending analysis. And this is just, I think, a good example of how Chia can do things. Actually, there's no publication associated with this. So this will result in zero anything. We're not going to email them. We're not putting it on the website. But when the governor filed legislation to measure and create incentives around primary care and behavioral health spending, Chia decided to get out ahead of any mandate that would come our way and start collecting the data and creating some baseline measurements. So we released a data, we worked with the stakeholders, we released a data spec over a year ago. We collected the data, we've been working it with our actuaries, and we now have a really nice picture of primary care and behavioral health spending in the Commonwealth, at least through the commercial plans. So not the public programs, but any spending either for commercially insured or things like Medicare, managed care programs, things like that, Medicaid, ACOs. So anyway, really interesting stuff. And the legislature, the attorney general, the auditor, the administration will all be using that, but it sort of isn't going to actually result in any public publication. It's the first year we felt it best not to do a publication. I think we will do publications in the future. But anyway, just wanted to mention that one bit of work we've been doing before concluding the executive director's report and turning things over to Christine Loveridge and Bridget Geyer, who are going to talk to us about the MHIS, the acronym we use. Is the Massachusetts Household Insurance Survey. And you folks feel free to correct me if that's wrong by all means. But the MHIS, it's our household survey, and it provides just a wealth of information about people's access to insurance, people's access to healthcare, affordability, all sorts of really great stuff. Before you guys, Christine, can I ask you, I was talking earlier about some stuff involving the survey. I think it was the health equity reports. Yeah. I must have said something that was not right. Would you care to correct? Is there anything you can say about those reports to correct misimpressions I created?
No, I think that you stated everything pretty correctly. I don't think that there was much to add.
Okay. Well, okay, good. That's I'm glad that I got it right. Okay, well, with that, I'm going to turn it over to you and Bridget to do the presentation on the MHIS and affordability issues.
Thank you so much, Ray, for that brief introduction. Good afternoon to the members of the council. I am Christine Loveridge, a research manager at Chia and the lead analyst on the MHIS. With me here today is Bridget Geyer, our associate manager. Today, we have been asked to share with you some of the new research we've been working on using the MHIS. So first, Alex, next slide, please. I will provide a quick refresh on the MHIS and an overview of the core research products that are derived from our data. I'll introduce our new reporting series dubbed Inside Looks and share some key findings from the 6 publications that we have produced so far in this series. After that, Bridget is going to share some highlights from our new research brief on unmet health-related social needs. And then we can wrap up with some thoughts about what's coming next for the MHIS, including an update on the 2021 survey with a bit of time for Q&A at the end. So first, a bit of background about the MHIS and the research products that are derived from it. The MHIS is an ongoing population-based survey of Massachusetts residents and about their healthcare experiences. So Chia and its predecessor agencies have been conducting the MHIS intermittently since 1998 and biennially in odd-numbered years since 2015. So our 2019 survey served as a great baseline pre-COVID, and our 2021 survey went into the field in mid-July and will be continuing throughout the fall. Data from the survey helped to fill in many of the gaps in our understanding on topics and issues that we can't necessarily ascertain directly through administrative data. Topics that we cover include health insurance coverage, the use of healthcare services and barriers to accessing care, and the changing landscape of healthcare affordability in the Commonwealth. We also introduce new modules each year on new and emerging topics of interest in healthcare research. So in 2019, we asked about the social determinants of health and more in-depth questions about behavioral healthcare. In 2021, we expanded questions about behavioral healthcare and added sections on the impact of the COVID-19 pandemic and the use and experiences of telehealth, among other topics. Also in 2017 and 2019, we fielded recontact surveys where Massachusetts residents who responded to the main survey were called back or emailed again with the contact information they provided so that we could ask follow-ups to get a deeper look on some key healthcare issues. The data that are produced from the MHIS are used by a wide variety of stakeholders, including the legislature and other policymakers, employers, insurers, and of course, sister agencies. So Alex, go to the next slide. We have 4 key products that come from the MHIS. So first, the MHIS itself is a core data asset that we make available to our stakeholders, particularly our sister agencies, as single-year data sets. And new this year, we're also in the process of creating a multi-year data set covering the past 3 cycles of the survey, so 2015, 2017, 2019. It requires a lot of reweighting of the file to be able to get there, but when we have that data set complete, the larger sample size of that multi-year data set improves the robustness of estimates for lower prevalence measures, as well as for smaller population subgroups. And so that will enable us to do a lot of that reporting on the healthcare equity issues at a lower geographic region and for those population subgroups, as Ray was mentioning earlier. We also plan to continue creating these files on a rolling basis in the future. Next, every year, of course, following the close of fielding, we produce a summary report of the findings of the survey with statewide trends over time on key measures like uninsurance, and breakdowns of all of the measures by a number of population subgroups, including socio-demographic groups, health coverage groups, and health status groups. So depending when the survey closes, these are typically published within the same survey year or shortly into the following year. Third, we produce in-depth analyses published in the form of standalone research briefs to take a deeper dive into topics of special interest. So 3 of our recent briefs include unmet health-related social needs, which Bridget will discuss in a bit, healthcare affordability for residents of the Commonwealth, and a technical research brief on methods for measuring population rates of uninsurance, including a comparison of data from the MHIS to other sources. And then in addition to the research briefs that are specifically based on MHIS, our unit is also producing briefs from other Chia data assets, such as our recent brief on lower wage workers using data from the Massachusetts Employer Survey. So that work is a little broader than just MHIS itself. And then finally, this year, we also began publishing a new series of short research notes, no more than about 2 to 3 pages in length. And we dubbed this series an Inside Look. The first 6 installments all focused on distinct aspects of healthcare affordability for Massachusetts residents. The Inside Look series is written with a more general audience in mind than the more researcher or academically oriented research briefs. And their shorter length makes them a little bit more accessible to those such as policymakers, members of the press, et cetera, who may not have time to be able to sit down and necessarily read an entire paper in depth. We were very pleased with the traction that we got from our first installments, a lot of interest from the press, from stakeholders. And so in the future, we do plan to expand that series to other healthcare topics, including both MHIS and other data assets from Chia. So now, next slide, please. I'd like to share a little more about the 6 installments in our new Inside Look series and some of our key findings from that series so far. So before I started, I just wanted to briefly explain the focus on affordability issues. Massachusetts, as you know, has near universal health insurance coverage, yet we are the most expensive state and the most expensive nation for healthcare costs. And we know from our main MHIS survey that almost half of residents indicate that they struggle with one or more issues of healthcare affordability. So 48.5% reported facing at least one affordability issue in the past 12 months. Over 1 in 5 had multiple and overlapping issues. So we wanted to do a little bit more in depth on special aspects of that we hadn't been able to squeeze into our main report. So the 6 briefs that we have published thus far focus on distinct topics in affordability, as mentioned. And so the topics are, first, problems paying medical bills, which means that the resident had difficulties being able to pay their medical bills or they couldn't pay them at all. The next one was on medical debt, which is a little distinct from problems paying medical bills because of the time component. Medical debt is about residents who are paying down medical bills, but doing so over many months or years. Next, high family spending on healthcare, which focuses on the total burden of all out-of-pocket spending for families relative to their income. Next, unmet healthcare needs due to cost, which are where residents are choosing to forego care that they felt was necessary due to the cost of that care. The next issue was unexpected medical bills. And so these are bills for which insured residents said that they had received a bill where their health insurance paid much less than they expected or it would, or perhaps didn't pay anything at all. So this concept of an unexpected medical bill includes, but is a little bit broader than surprise medical bills that have gotten a lot of attention in the media, in which the resident received an out-of-network bill for care that they had believed would be in-network. And then finally, we looked at high deductible health plans, specifically at the rates of enrollment, as well as the rates of experiencing affordability issues among those who were on commercial health plans with and without high deductibles, as defined by the IRS. So next, I'm going to share briefly some of our key findings from each. I'll go in the same order as I went over those briefs. So let's start with problems paying family medical bills. We focused on this inside look on the 92.5% of residents who had health insurance for all of the past 12 months, so that we could focus on the problems that were due to gaps in coverage under the resident's health plan rather than gaps in having insurance itself. On the left, the orange bar, you can see that among the fully insured, 1 in 7 Massachusetts residents, or 15%, indicated that they had problems paying family medical bills in the past 12 months. And then moving down from the top, you'll see there's significant variations by population subgroups. So this issue is the least common among elderly residents. It is the most common among the moderate income residents, so 139 to 300% of the federal poverty level. It's interesting to note in several of the affordability issues that we're highlighting, you'll see that U-shaped curve where the moderate income residents tend to be those with the highest rates of healthcare affordability issues. Likely this is due to the fact that that lowest income group has more comprehensive healthcare coverage through Mass Health or other subsidized insurance. And then finally, we also noted that residents with fair or poor health were twice as likely to have problems paying family medical bills, likely due to having more interactions with the healthcare system. We asked kind of what were the consequences, the real world consequences for families who were experiencing these issues. And we found a number of different distinct issues. So 65% reported cutting back on their family savings, 40% increased debt on their credit cards, and more than half, 52%, said that they were getting contacted by a collection agency within the past year. All right, next slide, please. So the next topic that we looked at was medical debt, or medical bills being paid down over time. Again, we focused on fully insured residents, and when looking at the sources of long-term debt, we focused on residents who insured at the time that debt was incurred. So starting on the left again, the orange bar, you see about 1 in 6, 17% of insured residents are reported that the family currently held medical debt. Similar to what we saw with problems paying medical bills, you see relationships where this is less common among the elderly, more common among residents with moderate incomes, and more common among residents with complex healthcare needs, such as fair or poor health status or 1 or more chronic conditions. On the right, we tried to break down what the sources were for medical debt. And medical debt doesn't have to come from one source only. For most people, it was a combination of different sources. The left bar at 81% shows that 81% of residents reported that they had debt from care that was covered under the health plan, but which required some form of cost sharing, whether a deductible, co-pays, or co-insurance. We break that statistic down into the next 2 bars. So the middle 2 bars, you see 68% said that they were carrying medical debt due to a deductible. 62% reported that they were carrying debt due to co-pays or co-insurance. The final bar, 52%, on the right, is the percentage of residents who said that they had medical debt due to care that was not covered by the health plan at all, whether it was for a provider that wasn't covered under the plan, or whether it was a service or some sort of prescription drug that wasn't covered under that plan. All right, The next brief that we published was about high family spending on healthcare. So we adapted a definition from the Commonwealth Fund for what constitutes a high share of income for families. So the definition that we used was 10% or more of family income for families over 200% of the federal poverty level, or 5% for those families underneath that level. You can see that in the orange bar, 1 in 7 residents who were fully insured all year, or 15%, spent a high share of family income on out-of-pocket healthcare expenses. Spending a high share of family income was most common among the elderly, which is perhaps not too surprising given how many elderly residents live on a fixed income and of course have higher healthcare utilization on average than other age groups. And we also noted some differences in family composition. So single adults and single parents with children were twice as likely as those living in households with 2 parents to spend a high share of family income on out-of-pocket expenses. Next slide, please. All right, number 4, the next inside look focused on unmet healthcare needs due to cost. So this is the most common affordability issue that we see in the Commonwealth. On the left, you can see that 1 in 4 residents chose to forego some type of healthcare in the past 12 months that they felt was needed due to the cost of that care. This is in spite of the fact that Massachusetts has one of the highest insurance rates in the nation. Children and the elderly experience this issue at much lower rates than non-elderly adults, which may reflect differences in insurance status, intra-household priorities, or other factors. On the other hand, we saw female residents more commonly had unmet healthcare needs than men. Perhaps as expected, higher income residents had the lowest rates of foregone care due to cost. It's interesting that 138% or below group is actually about at the same rates as moderate income for this issue. Those with fair, poor health or chronic conditions had higher rates of unmet need due to cost than those with none. That's probably not that surprising. On the right, we see that a variety of health services drove these unmet needs. So it wasn't just one type of care, it was many different types of care. However, you do see that several of these are items that are frequently carved out of medical insurance and therefore not subject to the same individual insurance mandates as health insurance. So the number 1 issue was dental care at 15%. But we also see 1 in 10 residents reporting foregoing medical care due to cost, which would typically be, for the most part, covered on the insurance plan.
It's interesting, you hear about prescription drugs, but dental was well out in front. And
Yes.
The chair is undoubtedly not surprised.
Nope. Huge unmet need.
Mass Health does, yes, and of course, Mass Health does have dental coverage, but yes, nevertheless, it is a huge need for sure.
Yep.
Next slide. Thank you. All right, so the next topic was unexpected medical bills. In 2019, over 1 in 3 residents, so 37%, who had health insurance coverage all year reported that they or a family member had received an unexpected medical bill in the past 12 months. We wanted to know whether this was just an occasional issue or if this had some persistence, but you can see that almost half or 45% of residents reporting having unexpected medical bills were receiving 3 or more of these bills within a single year period, signaling a persistent issue with these bills. And I'll note that on the 2021 survey, we're asking a little bit more of a narrow question about surprise medical bills. And so we're eagerly awaiting the data from that coming out later this year or early next. Next slide, please. Okay, and our final inside look was on high deductible health plans or HDHPs. In 2019, more than 1 in 3 privately insured residents in the Commonwealth were enrolled in a high deductible health plan, and that share has been growing over the past few years. HDHPs do exist in other insurance, but we are focusing on the commercial world since this is where most of them occur. HDHPs have been a topic of considerable controversy as overall healthcare expenses and premiums continue to rise. Both individuals and employers might find HDHPs increasingly attractive as they generally trade a lower premium in exchange for that higher deductible. That plan design might be great for individuals who don't expect to use much healthcare in most years and who can afford to pay the deductible when they need to. On the other hand, there's a concern that they may be a source of significant underinsurance for those who, due to a lower family income, really can't afford that deductible, or who have to keep paying that full amount year after year, for example, due to a chronic health condition. From the MES, we also know that HDHPs may be the only plan offered by an employer. And so there is also a concern about whether people are on these plans due to choice or whether because it is simply the option available to them. So we wanted to understand what the differences in enrollment rates were and the experience of healthcare affordability issues by some of the factors that might be driving whether population groups might be able to be more or less benefiting from the design of these plans. So we looked at family income as well as chronic condition status, sort of as a proxy for the need for healthcare on an ongoing basis, so that they would be potentially hit by some or all of that deductible in a given year. You can see that there's virtually, on the left are the enrollment rates, and you can see there's virtually no difference between those who have no chronic conditions and those who have one or more chronic conditions in terms of enrollment rates. We did see a significant difference in family income. 37% of those with higher income above 300% of the federal poverty level versus 28% below that level. However, it's worth noting that with 28% of those who are privately insured and under 300% of the poverty level on HDHPs, this is a group that could be very vulnerable to affordability issues. So it's worth noting that more than a quarter of privately insured residents in that income group are on HDHPs. When we turn to the part on the affordability, the rates of affordability issues that people report experiencing within the past year, overall, the HDHP enrollees have higher rates of affordability issues across all of these groups as well as statewide compared to their non-HDHP private insurance counterparts. You see overall statewide 52%, so more than half of HDHP enrollees in private plans report having affordability issues versus only 39% who are on non-HDHP type plans. If you look at the groups that, based on these proxies, you might expect to be more benefiting a little bit more from these plans, those who have higher income, those with no chronic conditions, you're still seeing 41% of those on HDHPs reporting affordability issues versus only 29% within that income and chronic condition group in the non-HDHP group reporting those issues. And if you look at the most vulnerable population group, those with income below 300% of the FPL and one or more chronic conditions, you see that 84% are reporting having healthcare affordability issues versus 68% for their non-HDHP counterparts. So, you know, we are seeing some significant correlations with affordability issues. Okay. I will pass it over now to Bridget Gayer to discuss some highlights from our new research brief on unmet health-related social needs.
Thank you, Christine. Next slide, please. First, I'll start with some definitions. So health-related social needs, or I'll refer to them throughout this presentation as HRSNs, are the immediate needs of a person or family that influence their healthcare access, healthcare costs, and overall health. These needs are influenced both by social determinants of health, which are more so the societal conditions that surround a community, as well as individual or family level circumstances that affect access to resources. There are increasing amounts of evidence that addressing individual or family level unmet health-related social needs can affect their healthcare access, can improve healthcare access, reduce costs, and improve health outcomes as well. So much so that screening for unmet HRSNs has also become a more frequently used tool in the patient care setting. For example, screening for food, housing, transportation, and safety issues are a key component of the CMS Accountable Health Communities model. Next slide, please. And those smaller scale data on unmet HRSNs is being used by providers to inform treatment plans or to refer patients to services. Our work in this area is really the first effort to collect data on unmet HRSNs on a statewide population level. And the objectives of this research are to document the prevalence of unmet HRSNs for Massachusetts residents as a whole and among population subgroups who are known to face economic and healthcare barriers. Next slide, please. So to collect data on unmet HRSNs among Massachusetts residents, a new module was first added to the 2019 MHIS Recontact Survey, which was fielded between December of 2019 and February of 2020. Surveys were completed by Massachusetts residents who reported whether their immediate family has experienced food insecurity, housing instability, financial strain, and employment instability. Next slide, please. So with the help of subject matter experts and looking at national surveys, we added to the MHIS a number of targeted questions to broadly capture instances of unmet HRSNs. On the right-hand side of the slide are the detailed components of each domain that was asked about. So I will walk us through the food insecurity domain. The survey asked residents about the frequency that they or any member of their immediate family worried that their food will run out before there was money to buy more, whether their food did not last long enough, whether they were hungry but could not afford food, or whether they got emergency food from a church, food pantry, or food bank during the last 12 months. And if any of these items were reported occurring sometimes, often, or always, the resident was considered to have food insecurity in their family. And residents who reported multiple domains of unmet needs were considered to have multiple unmet HRSNs for our analysis. Next slide. Now I will discuss a little bit about what we found in the data that was collected. First, over half or 52% of all Massachusetts residents reported at least one unmet HRSN in their immediate families in 2019. And over 1/3 or 34% reported multiple unmet needs in this region or in this realm. Next slide. So this slide will show the prevalence of each of the individual domains. So food insecurity, housing instability, and employment instability all affected close to 1/4 of Massachusetts residents and their families. And the most common unmet need was financial strain, affecting 34% of residents and their families. Next slide. So we broke out the rates of unmet need by population subgroups. And here is the family income breakdown. So starting from the top, among residents with very low income, defined as family income less than 139% of the federal poverty level, more than 3/4 or 77% had an unmet HRSN in their families in 2019. And maybe as expected, the rate of any unmet HRSN decreases as income increases. And moving down the chart, you'll see that when we were looking at who had multiple unmet HRSNs, you'll see that more than half of very low and low income residents reported having multiple unmet health-related social needs at 57% and 56% respectively. Continuing down the chart, we show the rates of the individual domains by family income. So for food insecurity, housing instability, and financial strain, all three of the lower income groups were significantly more likely to report these unmet needs compared to the higher income residents, which we define as 400% or higher of the federal poverty level. And finally, looking at employment instability, only very low income residents were significantly more likely to report this compared to high income residents. And for low and moderate income residents, this finding may indicate that employment instability is not the root of the issue, but rather maybe the wages and benefits offered are not meeting their family's needs. Could be indicative of this. Next slide. So next, we examined the rates of these unmet needs by race and ethnicity. There's adequate evidence of structural inequities that limit access to needed resources and drive poor health outcomes among marginalized communities based on race and ethnicity. And we found evidence of this in our data as well, as unmet HRSNs were experienced disproportionately by non-Hispanic, Black, and Hispanic residents. So starting from the top, 77% of non-Hispanic Black residents and 73% of Hispanic residents and unmet HRSN in their families. Most non-Hispanic Black and Hispanic residents also reported issues with multiple unmet HRSNs at 64% and 54% respectively. And then looking at the individual domains, non-Hispanic Black and Hispanic residents were significantly more likely to report food insecurity, housing instability, and financial strain compared to non-Hispanic white residents. And the differences within these individual domains were particularly notable for non-Hispanic Black residents, where levels of unmet HRSNs were, for all three measures, were more than double those of non-Hispanic white residents. Next slide. Lastly, we examined rates of unmet HRSNs by family type and structure. So whether a family has children or is headed by a married couple, domestic partners, or an otherwise unmarried person, we know this influences that family's level of need and availability of resources. And the combination of these factors resulted in some stark differences by family type. And across the board, what we found is that residents in single parent families experience the highest level of unmet HRSN. Particularly high was the rate of financial strain among single parent families at 58%, which was much higher than any other family type. Single adults without children were also more likely to experience any unmet HRSN and multiple unmet HRSNs. And it is important to note that about 30% of families in Massachusetts without children are single or partnered elderly adults. And so just thinking about this group and that it's not necessarily homogeneous in age or circumstance. Next slide. So to summarize our findings, our main findings from this research, the majority or 52% of Massachusetts residents experienced at least one unmet HRSN in their families in 2019. Multiple unmet HRSNs were less common, but still affected 34% of residents and their families. And lastly, unmet HRSNs were particularly high for residents with very low or low income, residents of color, and residents in single parent families. And what was particularly striking about this was that levels of food insecurity, housing instability, and financial strain for non-Hispanic Black residents and their families were more than double those of non-Hispanic white residents and their families. Next slide, please. So this research has several implications. First, as these statewide rates reflect levels of unmet HRSNs in 2019, this work can serve as an important baseline in understanding how these unmet needs have been affected during the COVID-19 pandemic. Second, this analysis found prominent disparities in unmet health-related social needs, which may contribute to widening health and healthcare inequities across the state. Third, the importance that data on these measures and unmet health-related social needs increasingly become part of the larger healthcare data collection system in order to provide much needed information to address ongoing challenges in healthcare equity. And lastly, the need for data on additional health-related social needs, such as access to transportation, social isolation, stress level, and interpersonal safety. These all may affect Massachusetts residents and their families, but we're not able to be included in the 2019 MHIS. We do plan to refine the measurement of this measure in future surveys in the effort to capture an even more complete picture of unmet health-related social needs across the state. Next slide. I will now pass the mic back to Christine so she can tell us what is next for the MHIS.
Thank you, Bridget. Next slide, please. Right, so the MHS remains an active research and data asset for both Chia and its stakeholders. I mentioned earlier a little bit, using our multi-year data file, we are currently building the chart books on healthcare equity issues, which will include deeper analyses than we have been previously able to report on by family income and by race ethnicity, particularly certain race ethnicity groups who simply haven't been able to report on in the past, as well as more detailed geographic information. Our 2021 survey is expected to wrap up fielding in early November. We are eagerly awaiting the results of this survey, which will be the first survey cycle since the beginning of the pandemic. Again, 2019 was the baseline. 2021 will really be a really critical and fascinating survey year for us. New topics include, of course, the impact of COVID-19 on everything: healthcare access, utilization, affordability, as well as impacts on coverage, such as impact on employer-sponsored insurance, enrollment in mass health, the connector, or other private plans as a result of the pandemic, and so on. We ask about the use of telehealth services, including offerings, whether people have ever used it, when did they start using it, was it during the pandemic, was it before the pandemic? We have also expanded a module on social determinants of health. So we have new topics on food security, housing stability and housing quality, employment stability issues, and other social determinants of health. Great, thank you so much for taking the time to learn a little bit more about our work on the MHS, and we have a bit of time to answer the questions by council members.
We don't have all that much time, but it's a really important topic. So thank you both very, very much. But I do want to get some questions out from the council. Questions? I didn't mean to stifle everyone. I just want to make sure Ray got his opportunity to talk about the research agenda.
I do have a couple of questions. Thank you for both of the presentations. Those were very informative and largely for me, not really surprising. I don't know if I missed it in the beginning, but I wanted to find out in terms of the information that was gathered, what exactly the sources were and whether or not you feel that you got a complete picture of residents of Massachusetts, or if there was anything that you might be missing.
So the survey has been fielded for many, many years, as I mentioned. When we field the MHAS, we attempt to get about 5,000 respondents, and it's not just about the total number of respondents, but the totals within specific categories and demographics, subgroups of key interest. So we try very, very hard to make sure that we have sufficient responses from race ethnicity groups, income groups. We have appropriate gender balance, and we do also and age groups, regional distribution, and so on. We do balance back the data that we have using post-stratification. So depending on the responses we get, then we balance back the results of the survey to match known population parameters from the US Census Bureau. We are always struggling, as every survey organization or every survey that is fielded at the sort of individual household level has been struggling over the past decade or two. Phone-based survey collection has become increasingly difficult. People, first because of the transition from landlines to cell phones, and second from the tendency of people on cell phones not to be picking them up anymore, in part due to spam. And so the best practices for survey methodologies have sort of varied over the years, and so the MHAS's design has gradually iterated to try to respond to that. So we did, depending on the year, we have incorporated address-based sample designs to complement that. In fact, the 2021 survey is a majority address-based sample design with a prepaid cell phone stratum as well. And this is, there's been a lot more research done in the past 5 to 10 years on address-based sampling, and due to the growth of big data, it allows you to more powerfully model who you think you might get when you attempt to survey specific households by address. And so we are able to some extent, to be able to capture those populations that that traditionally what phone-based or address-based sampling strategies tend to have higher rates of non-response with. So it is a huge challenge, but it is something that I think that we have been very pleased with in terms of working with our current survey vendor, and between our team and theirs have been responding to quite well in terms of being able to get a final data file for which we can produce pretty robust estimates for a wide variety of population subgroups.
Thank you. I appreciate it. Okay, I can only imagine the effort that goes into just even collecting the data as opposed to not even just reviewing it. The other thing I wanted to ask is, you briefly mentioned when you were talking about the high deductible health plans, what the definition was based on, and I just wanted to see if you could go back real quick and talk about what the actual definition is.
Sure. The definition of a high deductible health plan comes from the IRS. It is changed. It is updated with income amounts every year. But in 2019, when that question was fielded, it was an individual health plan for which the annual deductible was $1,350 or more. For family coverage, it is twice that, so $2,700 per year.
Thank you.
Mm-hmm.
Others?
I think we probably are going to have to pivot, but I mean, we actually could talk about this for a long, long time. It's an incredibly rich source of information, as I think you're gathering, and we're using it for so many different things. It's at very few states, maybe California, but very few states in the country have this level of insight into kind of their households and how they access healthcare and the impact of buying healthcare has on the family. So really remarkable work. Christine Loveridge and Bridget Gayer. And I don't know if there's any final questions before we move on.
Just thank you very much.
Great stuff. Great stuff. Okay, and we've reported on different aspects from the survey before, so you'll continue to hear about the work that we leverage the survey for. But I think some people think that it's, I don't know, a casual, surveying thing. It's a really heavy-duty, high-end methodology, statistically, kind of rigorous survey of the Massachusetts population. So great stuff. Great stuff. Thank you. Okay, if we could share the slides again, Alex, we can pivot to the next and final topic. So Chia's analytic priorities. To put this into context, actually, if you look at Chia's statute, one of the things that the Oversight Council is in fact charged with doing is helping Chia set its analytic priorities. And at the March Oversight Council meeting, Bill Geary said, are we going to be having a discussion about Chia's analytic priorities? Fair question. So at the June meeting, actually, why don't you go to the next slide? Thank you very much. At the June meeting, I laid out a framework for thinking about Chia, kind of, fundamentally who we are and what we do. And it was centered around two things: Chia's data assets and Chia's major analytic activities. So we're not going to spend any time on this, but this is really important context for thinking about our analytic agenda. And in fact, I should say, Chia is now actually engaged in an internal exercise to really look at our analytic priorities and see where we have some space where we can, shuffle things up and add some more things in. And the reason for this is that we're just coming out of a pandemic. We're very busy, but we're not as, under the gun as we were, say, a year ago. And we also, frankly, don't want to lose the lessons that we've learned over the past 18 months. And so we want to be thinking very consciously about just being the best health data agency we can be, because serious things happen from time to time. We also have a new analytic leadership team in place, so we've had some significant changes since the spring. So since the start of summer, we've been meeting as a team and starting to discuss Chia's analytic priorities. The APCD project is now coming to an end. So we're about to have access to a really powerful tool, and we're going to free up a bunch of staff from building that tool to going back to doing analytics. And then also in the wider world, the HPC just released their 2021 cost trends report. And that is a very important sort of North Star for us in terms of understanding what are the important policy questions that the Commonwealth is going to be grappling with. That guides our analytic agenda. You'll see that coming up shortly. So anyway, we're at this articulation point. We're talking about this internally. Today we will have very little time other than for me to lay some stuff out, and we can talk about it a bit. But at our next meeting, we can devote really the whole discussion to just talking about these the analytic priorities presentation will be just to discussing the priorities rather than me having to lay out all this kind of context. But anyway, I will not review this slide, but it really does start with our data assets. Kind of everything we do, it starts with our data assets, and those are the 6. We've talked about those before. If you could go to the next slide. I similarly will not review these in depth, but we talked about these last time. You can bucket Chia's major analytic activities into a number of categories. Because it starts with our data, there's certain things that we can do, there's certain things that we can't do. The top 3 are really our most fundamental capabilities. We have very good ability to measure healthcare spending, prices, and utilization. We have a good window into provider finances. And as you just saw, we understand a lot about insurance coverage and healthcare affordability. Below that, we can use those tools, if you will, and we apply them to some particular topics. So as you get to, for instance, health equity and social determinants of health, that's more of a topic that we can use our expertise in healthcare spending or insurance coverage or healthcare affordability to look at health equity and social determinants. Similarly, behavioral health, you're often looking at spending and utilization, things like that. We look at provider and payer equity, price transparency, and major healthcare system events. So I say this to lay the foundation that Chia has a bunch of key data assets, and we have sort of certain types of analytic expertise. There's a bunch of things the Department of Public Health does that you don't see on this list because it's a different area, different type of analytics. Next slide, please. Okay, so also, and then before getting to the analytic priorities, I just want to point out that although analytics is really important to us, we are a data and analytics agency. And so our priorities are not only in the analytics area, but we are starting Chia's leadership team to look out over the next 2 years to think about our priorities in 4 key areas. One is in data operations, because as I said, it's our lifeblood, and the scale and pace of that work has really exploded. And you saw some of that in the data release slide that Andrew shared, but there's actually other indicators of that as well in terms of linking projects and more. So we need to, and we're talking about how to come up with improve the efficiency, reliability, and transparency of our data operations. We do a really good job of it, but it's so foundational and it's grown so fast without a plan. We really want to revisit that and improve on it. Analytic priorities, that's what we're going to talk about today and next meeting. The APCD has been such a huge investment. I'm really pleased that it's a successful investment, but it's one thing to build the tool. We really need to make sure that the initial operations phase is something we focus on very carefully. And so we're not going to just flip the switch and walk away. We're going to be very focused. It's going to be an enterprise priority for Chia to make sure that the operations of that new platform go well, that we get wide adoption within the agency and from our sister agencies as much as possible. And then lastly, communications, as you saw earlier. I mean, although we're a data and analytics agency, a big part of doing that successfully is being able to get your work product out into the world. And so Andrew and I and his team have been talking, and we've working on some priorities for how we can do a better job with outreach and engagement. And in particular, wanting to take better advantage of video. We use such good reports, but as you've seen each one of these Oversight Council meetings, when Chia's staff talks about the reports, they really come to life and they can highlight the important aspects of it. And I think we need a communication strategy that gets our people out explaining our work product more often. But anyway, we have priorities in these 4 areas. If you want to flip the slide, please. So with that in mind, we are in fact starting to work through what Chia's analytic priorities ought to be. I think I'll just sort of flip past this slide, other than to say, obviously our enabling statute has a lot to say about what our priorities are. Similarly, we're a data and analytics organization, as I said, and so we have priorities that relate to our data operations, and then that informs our analytic priorities in many ways. Also, I just want to remind folks, we're driven by our mission, and that mission, we don't actually have a formal updated mission statement, but essentially it's to measure the Massachusetts healthcare system to create the factual foundation for better policymaking and program operations in government and more informed decision-making by private actors in the healthcare delivery system. But really our alpha priority is to serve the needs of the HPC, executive branch agencies, the legislature, the attorney general, and the auditor. Okay, so let's turn to the next slide. So as I said, Chia is now meeting to try to discuss what our analytic priorities ought to be. And I'm really going to just race right through this just so that I can end my talking and get to some discussion. But the way we're looking at our priorities, as I said, we're very busy with a full book of business as it is, but we also want to be looking down the road. It's particularly important with data operations because there's long lead times. And so if we're not looking down the road, we're going to be, scrambling to catch up more often than we'd like. So when you ask people, what are your data and analytic priorities, you tend to get blank stares. But the HPC recently came out with their healthcare cost trend recommendations, and implicit in every one of them is some sort of a data or analytic need that Chia could fulfill. So Chia's team is busy, and I'm not going to go into detail on these, but just these are the recommendations from the HPC's cost trends report. We're looking at each one of them and trying to understand, can Chia provide the data that the HPC needs to do its job? And the HPC, by the way, they can get data from other places, and they do, and they can get, national data and so on. But we feel a real obligation as best we can to provision them with the data and analytics they need. So we're looking through their recommendations very carefully to see which ones we need to do more work in, and to kind of weigh that against what we have bandwidth to do. So these are the HPs. I'll send around to everyone afterwards, or I encourage you to go to their website to see it. The executive summary of the cost trends report from the HPC, it really lays out, to me, it's the menu of health policy issues that are most pressing or among the most pressing in the Commonwealth. So we want to be prepared to serve those. So next slide. That finishes off the fourth bold heading there, finishes the HPC's recommendations that we're, as I said, parsing for assignments that Chia can take away from them. In addition to that, though, if you go underneath the dotted line, we're working through a whole list of topics that have come to us through different sources. And as I said, we want, even though we're really busy and none of these things are mandatory per se, some of them are pressing, are more pressing than others. We want to be sure that we're being proactive and not getting caught short. So we can talk about any of these in more detail. I'll actually send out materials before the December meeting that's maybe background on each of these. Some of these may fall off the list before then, but anything that's still under consideration, I'll give you some more background on. But just as an example, so things that we're considering, the federal government has established a new standard that providers, essentially doctors and hospitals, have to be able to share patient information in a friction-free way with things like, patient personal health records and services that patients choose to use. One question is, should Chia leverage that high availability, and they're great data elements, really great data elements are in the US CDI. Should we leverage that to start collecting patient level data elements from electronic health records? None of our data at this point is really pulled from EHRs. It's generally from administrative systems. So this could be a vehicle for us to start collecting EHR data. We're very interested in, so moving on to the second one, teasing out the ways that COVID has impacted healthcare spending, in particular understanding one-time costs versus ongoing. Next year's benchmark exercise is going to be interesting and important, to say the least. I think we'll want to understand, and this came up at the Health Policy Commission's recent meeting, how much of what we see in 2020 is one-time versus ongoing. Next slide, please. There really isn't. Okay, I'm going to do this in a very hitting the wave tops way. Number 3 is about actually collecting race and ethnicity data from health plans, but it needs to be something that's not just Chia imposed. It has to make sense from a mass health perspective, from actually the health plans. It has to make sense for their business uses. It has to make sense for lots of folks. It has to make sense for. So we're not going to just go out on our own, but we're looking at collecting really the key data elements that everybody wants to see: race, ethnicity, language, disability status. As I mentioned, we're doing this primary care and behavioral health spending analysis. It's been really well received. A lot of interest in updating the specifications and also considering doing an annual report on primary care and behavioral health spending. The HPC has expressed interest, and then their recommendations, underlying some of that is looking at not just health status adjusted total medical expenditures, which is how we report to them, and it's the basis for referrals in the PIP, but to look at unadjusted TME and other things like that. So we're looking at what would be involved in doing that. The Attorney General in her report on health equities called on not by, I think it did call on Chia by name, to create, to measure and report on commercial and mass health total medical expenditures at the census block group level. And so we have started working on that. We're actually going to give them an update, I think, in a week or so. We're looking to add geocoding to Chia's master patient index. We have geocoding. We've started to geocode some of our data assets. We're thinking about making it more of an enterprise feature. We started collecting discharge data from behavioral health hospitals a couple of years ago. We're discussing, should we be doing an annual report on behavioral health hospital discharges? We have census data and we have zip codes, and there's a whole lot of reporting you could do, or really any of our reports. If you just imagine breaking it down by communities that are majority minority versus communities that are affluent or what have you, we could use census data a lot more extensively than we do in our reporting. And so that's something that we're considering. The Institute for Health Metrics and Evaluation at the University of Washington has come up with a fascinating way of measuring healthcare spending where it all tracks back to a disease state, other than things like primary care or accidents. But if you imagine, like a pie chart or a tree map that shows how much spending is on cancer versus back pain versus knee surgeries versus cirrhosis versus, psychiatric care, all that. It's a really fascinating lens into healthcare spending. We're going to be talking to them. Maybe we ought to do a similar thing for Massachusetts. Creating a structured database of metadata about Chia's data assets. There's so much information about our data that exists in so many different places and in different people's minds or different people's heads that we actually think there'd be a lot of value in creating a formal structured database with information about Chia's data assets. Final slide, so then I can stop. The APCD, the new platform, when it's up and running, is going to have unbelievable capabilities for drilling down on questions of the day. One is what's driving the growth in hospital outpatient spending. We can't see that with our aggregate data. We'll be able to track that much more carefully with the enhanced APCD. Similarly, when we're going around discussing primary care and behavioral health spending, there's lots of different stratifications or drill downs people are interested in. We can do that with the APCD. Relative price is important for a lot of reasons, but when you use aggregate data, it's kind of just a single number for an institution. If we were to use the APCD, we could actually do relative price by different services or different locations or different things like that. With the enhanced APCD, we can start doing total cost of care analysis where it starts teasing out how much of cost increases or payment increases are being driven by prices versus utilization versus prevalence, severity, service mix, and more. There's still not a really good statewide provider directory, which is a problem. I don't think it's Chia's problem to solve alone, but it would help us a lot for many of our analyses if there was a really good one. And there's various sort of not ideal ones out there. And then develop a new transparency agenda to reflect recent federal developments. This came up at the HPC's meeting this week or last week. In terms of compliance with the federal mandates, Chia could certainly get any of the data that institutions are supposed to publish according to the federal rule. We would be able to get a hold of very easily, and maybe we should be a clearinghouse or republisher for that, things like that. So we're looking into what our transparency agenda should be in the post-federal transparency world. And lastly, and then I'm done, as I said, people don't always tell you what their data and analytic needs are, but sometimes they come out with things that if you read between the lines, it doesn't take much to figure out that there's a lot of data and analytic assignments in there. And so one of those is Mass Health's 1115 waiver extension that they're working on. They've been holding public hearings on it. Just throughout that, I think there are data and analytic needs that if Chia is thoughtful and proactive, we can get ahead of the curve and be in a position to serve Mass Health's needs as they get their new 1115 waiver. So I will stop there, but that's sort of the body of possibilities we're exploring, and it's a lot, and we will discuss this in December, and even between them, we can have individual discussions if anybody wants to.
That's terrific. And I'm so sorry Bill's not here, but he will definitely be there in December. So
I'll reach out to him individually for sure. I'll make a point of that.
Great. Thoughts from the council members? We do have about 5-6 minutes.
Yeah, sure. Ray, you mentioned that you might want to be updating Chia's mission statement, like you updated that briefly. I was wondering if do you guys have like a strategic plan or anything like that I mean, or myself or the council could review before we come into December?
Yes, absolutely. Actually, Yes, we have worked on Lori Kavanaugh, before she left, she and I and Andrew Jackman and a few others had worked on a really nice, actually some of the materials that you saw already, the kind of the bucketing Chia's analytic activities into groups, a few other things are a reflection of that work, but I'll circulate more of the materials so that you can have that for the discussion.
Awesome. Yeah, thanks, Ray.
Thank you. Others?
Ray, I would ask a question about, it looks like you had videos as part of what you might want to be thinking about in terms of data presentation. Would those include animated data visualization types of tools that make the data come alive more in terms of watching trends grow over time, or showing it sort of geolocated against a map where you might see heat maps of things? Does it include that type of presentation?
Yes, exactly. I think we do an excellent job, I think, with communications, and I think, and we're thoughtful about it, as you saw, but I also think that the world has changed a lot. And so I think that there's just different ways that we can do outreach, whether it's channels of interest, like try to build on, people that are interested in provider finance and, try to really cultivate those. And in particular, I think doing video presentations, it's so easy now. People are so used to it. I think we could engage people much more. So we're going to be coming up with a strategy for all the different things that we need to do in communicate, the highest return things we can do in the communication space to have more impact.
Yeah, I think that's really terrific. Just another question about, maybe we could in the future revisit this. I'm just thinking about the things you had as a potential, and noting specifically provider directory, and just thinking about that's the bane of existence in healthcare, is people cannot find across the board. And in thinking about something that Chia could do that would be high uptake, high value, there's even governmental mandates, federal mandates, that insurers have to know and have to have their provider directories updated. They're never updated, they're wrong constantly. And just thinking also about patient or consumer facing types of tools. I know we've thought about different portals, and that's another one where if it, even if it could tie to selections on the exchange, I just think about that one. So that would be a wonderful opportunity to kind of discuss the relative merits of the things that are on that list.
Absolutely, yeah. I was gonna say, it's too bad that we couldn't, because of the open meeting laws, it really constrains our ability to discuss it kind of we can certainly have one-on-one calls, but I think it's hard to have, like I was say, we could set up some optional sessions between now and the December meeting for people to tune into, but I'm not sure we can. So, but I will circulate materials that would be public record. It's all innocuous stuff that fleshes out these ideas so that people are in a position to have a better discussion in December about them.
Yeah, great. Thank you.
And we don't have to be done in December, by the way. Some things you obviously want to be ahead of the curve. Some of these things, it's specifically because some things have an 18-month or 2 year. It's just the time window said 2021 to 23. So these don't all have to happen right away.
And as you mentioned, you sort of offhand comment about the vendor options aren't too good for provider directory. It's because it's wicked hard. It's really super difficult to keep an ongoing updated. That is way more complicated than I think anybody thought on the surface. So I'm not surprised that there's very few vendors doing a good job with that.
I just mean, even in state, it's not even clear who, because on some levels, we could, in theory, but the Board of Registration in Medicine, in theory, but not all medical professionals are licensed by BORM. Mass Health sort of is the big 800-pound gorilla, but they don't actually cover the whole system. It's sort of like part of it's a question of who would be the one to do it and what would be the standard so that it would serve everyone's needs. And so that's why no one's stepped up and done it, I guess. But just we're frustrated that there isn't a good statewide provider directory. It would serve the public and it would serve a lot of analytic uses.
Colleen.
No, I just wanted to note on the provider directory, I'm sure you are aware, Ray, but the HPC was charged in the COVID impact study that we were asked to do in January of 2021 to put together and put out a provider directory. There's very little in the legislative mandate as to direction for that, but we have a while before we have to put out that part of the report. It's a 2-part COVID impact study. We put out the first phase of it.
I didn't realize that.
it's a little bit about like what are the essential components of a fully functioning healthcare system, one of which is having a robust provider directory. So just to keep in touch with us on that. But I also just wanted to say thank you for going through our report 2 business days after it came out and looking through and see how Chia can support us. That is absolutely wonderful. And I think for the edification of this Oversight Council, I'm sure you're all very aware, but our research teams meet on a bi-monthly basis to go through really methodology and compare notes and see where our teams can support each other. And so I think it's really amazing at a leadership level that you've taken the time to go through that and really figure out how we can work together moving forward. So thank you.
That's great. And we wish you luck on the provider report. One final thought for the analytic conversation. Seems like there are 2 types on your list. One is the things that need to be done to collect new data or new methodologies for linking, et cetera. And then the other is questions that people need to have answered. And this maybe as we think about them, those 2 categories, it's the latter one that is important. And then you say, okay, now do we have to collect in order to do that? So I can't wait for the next conversation in analytics. And I hope the bill will be on the agenda. Look forward to the conversation about finance. And really look forward to a conversation about the APCD, which will be functioning. I think I heard you say that. It's very exciting.
Yes, it will.
So very full 2 hours. Thank you. Thank the team for all the work that you do. It's terrific. And thank the council for spending 2 hours. And it will be an interesting conversation in December.
Sure. Thank you, everyone. Thank you, Chair.